Let's discuss chronic obstructive pulmonary disease, COPD, exacerbation. A condition where a patient with COPD experiences a sudden worsening of symptoms due to increased airway inflammation, mucus production, and airflow obstruction. Here's everything you need to know about COPD exacerbation. COPD is a progressive chronic disease that includes conditions such as chronic bronchitis and emphysema, both of which cause irreversible damage to the lungs and obstruct airflow. An exacerbation occurs when there is sudden worsening of symptoms beyond the patient's usual baseline, often triggered by infection, environmental irritants, or other medical conditions. The term chronic refers to the persistent and long-term nature of the disease, while obstructive refers to the limited airflow caused by damage to the lungs. Pulmonary disease refers to the fact that this condition affects the respiratory system. In a healthy individual, the lungs function by allowing oxygen to enter the alveoli, where gas exchange occurs, and carbon dioxide is expelled. In a patient with COPD, the airways and alveoli become damaged due to chronic inflammation, reducing the lungs' ability to exchange gases efficiently. Chronic bronchitis leads to excessive mucus production and airway narrowing, while emphysema causes destruction of the alveoli, reducing lung elasticity and leading to air trapping. It also leads to a loss of surface area in the alveoli. During an exacerbation, these effects are worsened, making it even harder for the patient to breathe. The most common cause of COPD exacerbation includes respiratory infections such as pneumonia or bronchitis, exposure to environmental pollutants like cigarette smoke or strong fumes, and cold weather. Other triggers can include heart failure, dehydration, and noncompliance with prescribed medications. Patients experiencing COPD exacerbation often present with increased shortness of breath, productive cough with excessive sputum, wheezing, and chest tightness. They may also exhibit signs of respiratory distress, including tachypnea, use of accessory muscles, and pursed lips. In severe cases, hypoxia can cause cyanosis, confusion, or altered mental status. A key diagnostic feature of COPD exacerbation is the presence of prolonged expiratory phases and diminished breath sounds due to air trapping. Unlike an asthma attack, which is reversible with bronchodilators, COPD exacerbation often results in persistent airflow limitation even after treatment. COPD exacerbation can progress to acute respiratory failure if the patient is unable to adequately ventilate, leading to the dangerous levels of carbon dioxide retention or hypercapnia and severe hypoxia or low oxygen levels. This may require advanced airway management and ventilatory support. To manage COPD exacerbation, you should first ensure the patient is in a position of comfort, typically sitting upright to improve lung expansion and making it easier for the patient to breathe. You should provide supplemental oxygen as needed, but be cautious not to administer high concentrations of oxygen, as some COPD patients rely on a hypoxic drive to stimulate their breathing. Target oxygen saturation should be between 88 and 92% for patients with COPD. Let's explain a hypoxic drive. Most people breathe because their body notices that there is too much carbon dioxide in their blood. This is called a hypercapnic drive, and it is the normal way the body controls breathing. However, people with COPD have trouble getting rid of carbon dioxide, so their body gets used to having high levels of it. Because of this, their body stops paying attention to the carbon dioxide levels and instead starts using oxygen levels to decide when to breathe. There are certain receptors inside the blood vessels that can monitor oxygen and carbon dioxide levels. Those receptors are called chemoreceptors. When the body starts using the chemoreceptors to sense low oxygen readings to initiate respiratory drive, the patient is said to have a hypoxic drive. This again is called a hypoxic drive, meaning their body tells them to breathe when their oxygen levels get too low instead of when their carbon dioxide levels get too high. This is why we have to be careful with administering oxygen to patients with COPD. People with COPD rely on low oxygen levels to tell their body to breathe. If they get too much oxygen for too long a time, their body might stop feeling the need to breathe because it's no longer sensing low oxygen levels. This can make their breathing slow down or even stop, which is very dangerous. This is known as knocking out their hypoxic drive, or knocking out their respiratory drive. If you notice that a patient's respiratory drive is slowing after oxygen administration, you should immediately turn off the oxygen and begin positive pressure ventilation without supplemental oxygen. If the patient shows signs of severe respiratory distress or impending failure despite oxygen administration, consider continuous positive airway pressure, or a CPAP device. Want to watch the full video? Watch the full video and get so much more with your full access membership by going to howtonremt.com or scanning the on-screen QR code now.